Sima, is Mayan joining?
I'm already there, sir. Good morning, sir.
Oh, good morning.
Okay. Sakshi ma'am, please start, ma'am.
Good morning to one and all. I think Dr. Soma Shekhar has also joined. It's showing in the participants list. So I'll just introduce myself. Maybe then sir can take over. I'm Dr. Sukshma Jain and I'm working as a faculty in Government Medical College Hospital, Chandigarh. Firstly, thanks to all the participants who are actually inviting us for so many of the queries, which is also causing a brainstorming exercise for us. So learning is a two-way process and we are really thankful to you people. So and thankful to Pratima who had been coordinating so nicely. So the various speakers for the day are who will be helping to resolve few of your queries. And if some of these are left, we can take it later on. So we have with us Dr. Shashidhar and he is in St. John's Medical College. We have Dr. Rashna, Mayank, Dr. Seema, and we have Meena Joshi from AIMS. She is very dedicated. I don't know how do you designate. In our place, it's called as nursing officer, senior nursing officer. So I call you by that only. And she is highly dedicated to various newborn issues. And if sir has joined, I think Dr. Soma has also joined, so he can take over and then we can start. Is it okay, Pratima?
Yes, sure. Somashekar sir, we welcome you, sir. Can you hear us? We have audible. Yeah. Okay.
Yeah. After you loud and clear, I'll keep your switched off because I have connections. But
Yes,
you can go ahead. So we have not yet started it.
Yeah, sir. We were waiting for you. We actually we need to start the first presentation,
Okay.
sir. So you can.
Yeah. Thank you.
Yeah, Dr. Shashidhar, please, you can.
Yeah. So good morning, everyone. The first thing we learned in delivery room care, which was the topic of this week, was that preterm babies need to be resuscitated in a timely fashion. Dr. Rishikesh Thakur's webinar taught us that preterm babies have a lot of issues. If you see a 27-week brain, it looks like a groundnut, and by 38 weeks, it should develop all the convolutions and appear like a walnut. So there is a lot of maturation which goes on from 27 to 38 weeks also. So a preterm baby brain is precious and time is brain. So this analogy is used a lot in stroke for adults and it's the same for newborn and especially a preterm newborn. So when you are resuscitating a baby who is especially preterm, the first thing you should do is to be prepared. That is because if you see the overall newborn mortality, even in 2016, the highest majority of newborn mortality was caused due to preterm birth complications, about 43.7%. The next was infection, the third was intrapartum related event. So if you combine the two intrapartum related, that is hypoxic ischemia, asphyxia, and preterm birth, they account for almost 65 or 2/3 of causes of newborn mortality. And when you say preterm complications, the highest number of deaths occur in the first day, and among that, the highest number of deaths occur the first hour of life. So that's why this hour is called the golden hour, where we have the golden opportunity to save this baby's life by doing certain basic things right. Because this preterm baby is at risk in the first hour of asphyxia, hypothermia, breathing difficulty, hypovolemia, and hypoglycemia. If you add to this IVH also, then all this to be taken care of in the first hour of life, which is called the golden hour. to take care of asphyxia is the primary goal in the labor room when we go as a team. Hypothermia, which has been discussed extensively in the last week. Breathing difficulty, which was discussed slightly, what to use, how to use. And it's again going to be discussed under CPAP. Hypovolemia, taking care of low volume in low perfusion state. Hypoglycemia, maintaining blood sugar levels, getting an IV line inside within the first hour of life. That's why the first golden minute is called the golden minute, because that is the most important time of precious baby's life where you should do something if the baby requires your support. So we already know why these babies are at risk of all these issues. For example, the baby is at risk of hypothermia because of large surface area, loss of subcutaneous fat, poor skin, poor response to the external stimuli. Babies at risk of RDS because they have less surfactant. Babies at risk of asphyxia because they have poor muscle tone, brain immaturity. Babies at risk of hypovolemia because their blood volume itself is less. Babies at risk of hypoglycemia because they don't have enough stores. Those are the primary reasons. So what do we do? Our primary goal in the first 1 hour of life is TABC. Temperature, airway, breathing and circulation. So wherever you go, whatever the situation is, the first thing for a newborn baby which is to be done is temperature, followed by airway, breathing and then circulation. So the primary fundamental thing is to anticipate. Whenever you are faced with a preterm delivery, anticipate that this baby is going to have problems. So well begun is half done, and in the first hour of life in the delivery room, if you can make it a golden hour in the baby's life, and if you are prepared, then I think from next presenter onwards, they're going to say what exactly we should do once you start being well prepared. Thank you.
Thank you so much, Dr. Shashidhar. And as you rightly, Somsekhar. As you rightly pointed out, preparation is the first step, and let us start with the equipment check. And Dr. Rachna will be discussing what all to check, and requesting all the participants to please post the questions on YouTube chat, which is streaming live. Thank you.
Family, how to unmute.
Can you hear me now? Hello?
Yes.
I think the most important issue in resuscitation is, or I should say the key to a successful newborn resuscitation is anticipation first, as already pointed out, and the second is preparation. So we need to prepare the equipment, which is, next slide please, which is required to manage the physiology as has been pointed out by Dr. Shashidhar. So you look at the physiology, first is the warmth. So we all know that the radiant warmer should be at least on 30 minutes prior to the receiving the baby. And along with that, we need the clean towels or blanket, which again have to be preheated. So this way you will reduce much of the complications occurring because of a baby coming out wet from the mother's womb. The second is the airway clearance, and for this there are various devices which are used depending on where you're practicing. You could have a bulb syringe or a mucus sucker. Most of us are very we're mostly using the mucus sucker, or you could have a 10 French or 12 French suction catheter which is attached to a wall suction. But this has to be set at 80 to 100 millimeters of mercury. And this is the equipment check which has to be done prior to each and every delivery, because you do not know when you are not using that suction machine, somebody may have changed the suction pressure. So this is very, very important. You cannot have more than 100 millimeters of mercury in the suction apparatus. The third is a meconium aspirator, which is shown in the last part, the transparent tube-like structure that you can see here. This is used when you have a meconium delivery. Then for the auscultation to see the heart rate, you always need a functioning stethoscope. Next slide. Next, please. Coming to another very important part of resuscitation, that is the oxygenation. So what are the equipments you require to give oxygenation? One is the mask. It could be a flow inflating bag or a T-piece resuscitator. The gas source, and this should be kept on just before the delivery at about 5 to 10 liters of per minute of flow. The oxygen blender, especially in case of preterm babies, should be set at 30% prior to the delivery. The pulse oximeter probe should be kept ready, but it should not be attached to the oximeter. And when the baby is born, after that, we first attach the oximeter to the baby's right hand and then attach it to the pulse oximeter monitor. The next part is the ventilation. So for the ventilation, we can use the bag and mask device with the preterm and term mask. Both should be kept ready. There was a question in the chat box, which I'll be addressing here. But before that, I think just keeping the bag and mask ready is not enough. You need to check whether it is functioning or not. So there are 3 steps. You have to attach the mask depending on the pregnancy, whether it's term or preterm. You have to attach the appropriate mask to the bag and then check whether the bag is, when you press it, whether the air is coming out, whether the self-inflation is taking place or not. And most important is whether the pop-off valve is functioning or not. Then you attach an oxygen tubing and you can keep it connected to the blender and have an 8 French feeding tube for use during ventilation. The next is intubation. So here the laryngoscope, and it should be functioning. That means you need to check whether the batteries are working or not, have the appropriate blade sizes of 0 and 1. Size 00 for extremely premature babies can be also kept if you have. A stylet, it helps in intubation. The end-tidal CO2 detector, if you are able to have it in your unit. But I think many of us do not have that, but it doesn't matter. You can also see whether you're in the right place by looking at the moisture which is occurring in the tube once you intubate the patient. And now we have also come to the use of laryngeal mask airway. There is evidence which says that this can also be used as a mode for intubation. Size 1 is the appropriate one, and a 5 ml syringe, because you'll need to inflate the laryngeal mask after you put it in. Medications, the most important is adrenaline, and it should be kept at 1:10,000 dilution. In India, we have the 1:1000 preparation, so therefore we need to dilute it before resuscitation with 9 ml of normal saline and keep it labeled and ready. The umbilical venous catheter is to be kept ready, and along with the normal saline. So in medications, I think these 2 are the most important ones which should be around. For thermal regulation, we need a plastic bag or plastic wrap, warming pad if it is available. These are chemically warmed, and a transport incubator should be kept ready and on in case you need to transfer the patient. Now, in preterm delivery, some of the equipment which has to be given extra attention is the thermoregulation. So you need to maintain the room temperature where the delivery is occurring at about 26 to 28 degrees centigrade, along with the availability of the plastic wrap. So in my unit, we do not have the plastic bags, but what we do is we use the normal plastic wraps, sterile wraps which come, drapes which come, and we hold the baby in that. For airway, for preterm deliveries, at least 8 to 10 French. For breathing, we have the preterm bag and mask, which is 180 to 250 ml. The blender, an essential component, the T-piece resuscitator, the pulse oximeter with the probe, laryngoscopes with 0 and 00 blade size, and 2 sizes of endotracheal tube, that is 2.5 and 3 mm. There was a question in the chat box which said, can we use T-piece resuscitator as a first line instead of the bag and mask? I think there are studies which are coming up. Probably currently, maybe we are not using it regularly, but as we do the resuscitation program, we will come up with these answers also. But there is a study which has been published in pediatric research, which has shown that if you use a T-piece resuscitator for initial resuscitation, then probably the complications in the baby, like decreased intubation and decreased incidence of bronchopulmonary dysplasia, can be there. And for circulation, you need the umbilical catheter at least 3.5 to 5 G. Thank you. So we need to keep everything ready, anticipate.
Thank you so much, Dr. Rashna. And once we have checked the equipment in the delivery room and the birthing areas, the first and foremost we have been teaching, and we all know as the neonatologist and who are providing neonatal care, that temperature. Without temperature, we cannot move ahead in any intervention or any procedure, and it applies to the resuscitation also. So last week was dedicated to thermoregulation. Dr. Saksham will be re-emphasizing the importance and especially in context to the delivery room. Dr. Saksham, I invite you, please.
Thank you, Pratima. Just a minor correction. I am Sukshma. I am not Saksham.
Okay.
Saksham is means microscopic. So just a minor correction. It's okay.
Okay.
It's a
Dr.
difficult
Saksham.
name to pronounce. So, first of all, I am grateful to Dr. Somashekar and his team who very exhaustively covered last time temperature maintenance in delivery room. So, when we talk of a important issue, we do need to understand what is the magnitude of the problem and why it is more common in preterm, which was exhaustively covered even the last time. So, I don't think I should re-emphasize upon that. I'll be talking mainly about the practical aspects of it. So please go to the next one. So this was I found from a QI study, and we should keep on doing QI. This was for maintaining temperature in the delivery room, and the things that worked for them was checking delivery room temperature. So some of us may not be having this room thermometer with humidity, which is depicted in a digital format. So this mercury one room thermometer is difficult to read, so please avoid them. It should be digital so that you can see it from a distance. And Dr. Ashna already told about turning on the radiant warmer, ensuring warm blanket, the wraps. Wraps can be of various types. It can be a cling wrap. It can be simply because in most of the hospitals in government setup and corporate setup, there are coming this sterile plastic drapes. So they're good enough. And then you have to ensure about the skin to skin contact. The biggest thing that we keep forgetting is team members, how to keep engaging them, talking to them beforehand. So all of us are doing our best, but what we do is we receive a baby and get done with the things. So we are not making good efforts to prepare it for the next team. So once you have used everything, the best way is you yourself prepare for the next delivery. And the second team or the yourself, if you are there are more such babies in one shift only. So you just recheck as an obsession. Please believe me, checking of all this has to be done like an obsession, even if it was that you received and you used everything 10 minutes back only. So prepare for the next delivery for all the equipments and checklist of the equipments before the second delivery happens, and this preparation to be done by the person who has used the whole of this equipment for the particular delivery. So the next one, please. Next one, please. So it's just a picture to show that you can have a digital thermometer. Digital one will display upon the temperature and humidity. Somebody asked in the chat box that how to maintain temperature of the delivery room when central heating is not there. Some of the units, especially in SNCU, central heating is not there. In most of these where we visited in various primary health centers and SNCUs, so they had been using heaters or 400-watt bulbs in various areas to make the room warm. It's okay. You can use them and then you can have a digital display whether the temperature is maintained or not. And it's well known for years, for long that from our ancestral time, if we keep a pan filled with water, it will evaporate and this will help in maintaining the humidity. Other than few of the months, normal humidity of 40% is maintained. Rather, it's a big issue in coastal areas also. And even in the northern India, some of the months humidity becomes so high, especially July, August, September, that we are more worried about the infections. So don't worry, the humidity is usually maintained because these rooms, the delivery rooms, they are not closed chambers. So these rooms have got an entry and an exit gate both. So in order to prevent any draught of air coming, so this just picture to show that the cot should be not near to the entry gate or to the exit gate. So it should be away from both entry and exit gate. And warmer should be kept at right angle, not parallel to the wall, so that conduction losses are further decreased. These are just some of the practical tips which will help in maintaining the temperature. And Dr. Ashna already talked about using the pre-warm linen. So you will be using minimum of 3 pre-warm linen. One in which you receive the baby, one with which the one in which you receive the baby, you are going to clean the baby with the same one. And one is where the baby is received. If the baby is received in the radiant warmer, so it also has to be pre-warmed. It becomes warmed if you keep your this warmer switched on half an hour prior to delivery. And the third one will be when you remove this wet linen, you have to wrap again in a warm linen. So this will again help in maintaining the temperature. The next one, please. So this is to just talk about some of the evidence which is there on thermal care in the delivery room. So it could be in form of barrier to heat loss. Barrier to heat loss in this very low birth weight baby could be in form of wrapping the baby. So this baby is being wrapped in a plastic wrap. Somebody asked that why do you wrap a baby who is moist? Inside the womb, the temperature is 0.5 degree further higher. It's 38 degree. So baby is coming out of a warm liquid bag. So once the baby comes out, so the skin as such in premature is also very fragile. The epidermis has got only 4 layers, unlike us where we have got 10 layers, or a term baby where it is 6 to 8 layers. So what you have to do is you don't have to rub it vigorously. You have to avoid any evaporation losses. So wrap the baby in the plastic sheet, this warm wrap only, and just clean the head. On the head you apply a cap. Rest of the baby just below the neck should be wrapped in a plastic wrap. If you have applied a cap, you can further cover if you have a bigger plastic wrap covering over the cap part also with a plastic wrap. It's okay. Some of you have got zip pouches, that is why I'm telling that. So it has been seen, the studies have been done in both preterm, term, the babies who are 300 grams, 3,000 grams or 2,000 grams also. So it has been found in very low birth weight baby. You can see the number of the babies they have enrolled in various trials is more than 1,500. It has been helpful in maintaining the core temperature for 2 hours. And with a significant confidence interval in a narrow range. So precision of the study was high, of all this pool analysis was high. And another was that, please go back to the previous one only. So fewer infants had hypothermia on admission to NICU because the temperature was maintained for approximately 2 hours when you were using this. So again, the risk reduction was high, up to 33%. So remember that while we are not rubbing or removing, for each ml of evaporation losses, you are losing up to, it's a very high calories, 560 calories of heat is lost. So that is why we wrap them in the as it is without cleaning them or without wiping them. But obviously you have to remove the wet sheet which was there in which the baby was received. So please go to the next one. So another is using the external heat source. One is your radiant warmer. Some of you might be using incubator, but most of these are open care systems only. It's only after post-resuscitation you put them in incubator. Otherwise, they are open care system only. So the skin-to-skin contact. This is very early skin-to-skin contact. It has been again studied in various studies in bigger babies also, where it had been effective. And as per the WHO guideline, there should be one birth attendant or birth companion present who helps the baby later on in breast crawl. So you receive the baby on the abdomen of the mother. And last time in the last presentation, even the picture were shown how in the cesarean also they could receive the baby. Once the baby is received and cord is clamped, then the baby is put on the breast for breastfeeding. So you receive the baby on the abdomen of the mother if it's a vaginal delivery and then do a breast crawl. Problem is here we are talking about the preterm babies. So in preterm babies, it's a very small study by in 32 to 34 weeker who were up to 1,500 gram. It was done in Norway, but this study had lots of bias where skin to skin contact was tried. Actually, these smaller babies, they tend to have some respiratory distress or TTNB in all gestation, all age, if it was not a product of the vaginal delivery where the labor was active, labor was not induced one. So they may land up in distress. It was a small trial only. Otherwise, in bigger babies, it has been successfully tried. And these babies were more than 1200 to 2200 gram. And there was a significant reduction, risk reduction was there in reducing the hypothermia by giving a very early skin to skin contact. But unfortunately, it is everybody is skeptical in trying this procedure in very preterm babies who are smaller, 1200 to 1500 gram. Next one, please. Next one, please. So this is post-resuscitation care. It will again come, so I will not go into depth. Just a part about the temperature. So breast crawl and ensuring breastfeeding. This will keep the baby warm. Don't weigh the baby for an hour. And don't do bathing in the delivery room. Bathing is a big query. It was previously also dealt and lots of unresolved issues are there, but we do not motivate any bathing in the hospital. It's just the sponging which is done. And then go for a warm transport. Problem is that we have lots of issues. We know them. We try to resolve them. It's better to first estimate the magnitude of the problem. In all neonates, measure temperature within golden hour, pre-transportation, and once baby reaches to NICU. So make a record of it maybe over a week or 10 days, and then do a fishbone analysis if you find that your babies are not in the range of normothermia of 36.5 to 37.5. And then you can go for various small quality improvement studies of hypothermia, management or prevention in first golden hour post-delivery, the one who are reaching to NICU within few minutes or hours post-delivery. And you can do various PDSA cycle that will give you various logistics of your area, which one to adapt or adopt or abandon. Thank you.
Thank you, Dr. Suksham, Dr. Sashidhar, and Dr. Rashna. Maybe we will have a few questions for 3 to 5 minutes, and then we'll go to the next speaker. Is that all right, Pratima?
Yes, sir. Sure, sir. Yeah, there are questions in the chat also. Yeah, yes, sir.
Okay, so there is one question I think I'll ask Dr. Sridhar. The question is related to by I think Rima Garegrat. She asks, can we warm the linen on the top of the warmer and then use it as a pre-warmed linen? I am guessing this question is related to putting it over the warmer and not on the bassinet of the warmer.
Yeah, so we would not advise that. Because vents on the warmer are meant to dissipate heat. And if you put something on the top of the warmer, they block all the vents. And your warmer can get spoiled within its lifetime. And also there can be short circuits and they can cause some heat injury, heat damage, and it can get overheated. So we don't advise putting, though it's routinely done, putting anything on the top of the warmer. If you want to warm, the best place is below the warmer on the bassinet. Right, sir?
Yeah, I think that's correct. So we don't want to do that. That's nice. I'll ask a question, Krishna Das, on equipment check. She mentioned about checking the bag and mask, etc. before the delivery. Now, I wanted to know if she or anyone has heard or used an ambu bag with a PEEP valve.
Yes. I have not used, but we have one unit which has it. So I think that is a good idea because you can regulate, if you can afford it, it's a good idea because you can regulate the PEEP that you're delivering to the baby. It is much better than using a normal.
Regarding the
yes,
normal ambu one. So question again is related to, so normally when we take resuscitation, we say there is the TPs, there's a bag. The bag, a self-inflating bag, and the third is the flow-inflating bag.
Yes.
Now, which one is better? And I don't think there are many studies related to that. But can you discuss? Can you maybe say which might be better, in what situation it might be better? Can you discuss that a bit?
I think it depends on the experience, because if you have a flow-in feeding bag, it is entirely controlled by the person who is giving the breaths. So if your experience, you need a lot of experience and practical experience in using that. Mostly it is used by the anesthetist. I have not personally used it. As far as the T-piece resuscitator is concerned, I think it is a good device because you can set both the PIP and the PEEP. And so you know exactly how much you're delivering, approximately near about how much you're delivering to the baby. And whenever you're using the bag and mask without the PEEP valve or the PEEP valve, I think the main idea is that you should not aim for too much of inflation of the chest, because what we need is just the heart rate rising. So that is an important point, I think, in the resuscitation room that must be kept in mind.
Thank you. I think Dr. Shashidhar mentioned this in the telegram that heart rate is the most important indicator of resuscitation, and chest rise may not be always because you tend to stress issues. People would theoretically prefer TPs because you know exactly what pressure they deliver, but I guess there are no studies in human neonates to suggest which are better. There are mechanistic studies or studies that are done on mannequin, St. John's, but it really depends upon who is doing the resuscitation and the equipment and how much that person is familiar with. So as with ventilators, preferable to use ventilators, etc., which you know and you have used it, rather than buying a new fancy one and causing issues because you're not experienced with it. Yeah, so I think we can ask another question now. This question is to Dr. Sukshma Jain. Is that correct? Whether cord pH decides the clinical management?
See, clinical management in the delivery room is not being decided by the cord pH. It depends what you are talking about. Whether you are talking about management in the delivery room, when you are resuscitating the baby and prolonged resuscitation is happening, you are not looking at cord pH before giving the normal saline bolus. Okay. So the second thing is whether cord pH will help us in deciding whether to feed or not. So feeding, if your pH is very bad, less than 7 or so, don't be very aggressive, because gut, as you know, gut, kidney, they are not the brain sparing area. So when there is any asphyxia or compromised situation, most of the blood will go to SVC and the blood will go to brain, heart, lungs. So blood going to the intestines is less. So you will have intestinal ischemia, which will be healed by reperfusion later on. So don't be very aggressive if pH was 7 or less. And if pH was in between 7 to 7.2, you may give a trial of feeding. And this feeding may vary from 5 to 20 ml per kg, your minimal enteral nutrition, for few hours, 4-6 hours or so. And then you can, after 24 hours, rapidly increase if you find that baby is tolerating and there are no signs of feed intolerance. So that is for the pH. Otherwise, cord blood gas at the time of initial resuscitation will not decide your resuscitation. You will go by the algorithm of resuscitation because you will send it, you will get a report. So it is not going to decide at that time your first golden hour or first golden few minutes for the management of on the basis of cord blood gases. And they are mainly for prognosticating.
Correct. Yeah. So I'll just ask another question. This is related to adrenaline. 1.1 is direction is once made for how many hours it can be kept, and at what point diluted injection can be used if it is not opened. Is Dr. Prakath's question.
I think for especially if you're doing a resuscitation for preterm babies, we should not keep the solution. If you have not used it, you should discard it, because adrenaline is not a very costly drug. But otherwise, for other resuscitation, they say if you prepare a solution, the stock solution can be kept at least for 24 hours. But I don't think so. I would advise it if we're doing it for newborn babies, because the chance of infection becomes more. I don't know about the rest of the practice. I mean, Meena and all can, I think, share their experience.
Yeah, we don't keep any.
So another you don't keep any stuff that Madam Meena?
Yeah, we don't keep anything which is any ampoule which is broken is to be and made preparation is made is to be discarded then and there only. No stock solution, nothing. So only costly antibiotics we keep for 24 hours. Rest we discard. Once a vial is open, ampoule is open, is to be discarded. We don't keep.
I just wanted to make a comment on the attachment of a pulse oximeter. The NRP mentioned that attach the pulse oximeter to the patient for some wash. But there is a study from PhD published where Dr. Praveen Kumar and one of his MDM students, which said that attaching it to the machine first and then to the is a faster saturation signal. And if you actually look at both the studies, by statistically, not really important. Comes from which was done in kept in the NICU, while the basis of the recommendation comes from base of RCT done in actually within the delivery is more kind of representative of the population. Dr. Preterm article and Telegram group later on. I think presentation and then we do questions.
Okay.
Dr. Maya, can you please go ahead?
Okay, thank you, sir. Thank you so much. So I'll be briefly going through the steps of neonatal resuscitation algorithm as has been given in the latest neonatal resuscitation program guidelines in 2020. So next slide, please. Yes, so this is the brief overview of what has been mentioned in the 2020 update. The algorithm essentially remains the same as the 2015 algorithm. There's been some minor changes which are in the text, mentioned in the text. However, the algorithm overall looks the same. And we'll be looking at each of these steps step by step. So next slide. Yes. So the NRP algorithm begins with antenatal counseling. We need to look for the risk factors in the pregnancy. So if there are one or more risk factors, then the number of personnel required for resuscitation increases. So if there's uncomplicated pregnancy, we would require one person who is well versed with NRP with all the steps. So however, if there are any risk factors, any additional risk factors which is present in the pregnancy, be it preterm delivery or meconium stained liquor or this preeclampsia or gestational diabetes, then there would be requirement of two personnel who are trained in NRP. So once the birth has taken place, we'll be looking at three questions. Is the baby term? Does the baby has a good tone? Is the baby breathing or crying well? So if the answer to all these three questions is yes, then we'll go for the routine care. The routine care would include warmth, positioning the airway, clearing the secretions only if needed and not as a routine, and drying with ongoing evaluation. So let's look at some of the important aspects of routine care before moving on to the other steps. So next slide, please. So So the two important aspects which are to be discussed here is delayed cord clamping and skin to skin contact. So there has been a lot of emphasis now on delayed cord clamping, as it has been found to be very beneficial in term as well as preterm infants. It has been shown to increase the hemoglobin levels, the iron storage, the decreased requirement of transfusion, as well as it has been shown to smoothen the transition at birth for term as well as preterm infants. So there's less incidence of IVH, there's less incidence of NEC, and there's a better blood pressure maintenance after birth if the cord is clamped at least after 30 seconds. So this has been previous slide, please. So the recent guidelines has mentioned that the cord should be clamped at least after 30 seconds for all vigorous newborns. And by all vigorous newborns, we mean if the baby is breathing or crying and the baby has a good tone. So all such infants would, we should be delaying the cord clamping for at least 30 seconds. Next slide. The other important aspect would, for all the stable newborns, we should be giving skin to skin contact with mother. So once the baby is born, while the cord is being the cord clamping is being delayed, the baby can be put on the mother's abdomen. After the cord has been clamped and cut, the baby now can be shifted between the mother's breast, as we have been doing in Kangaroo mother care. The same position is appropriate for skin to skin contact as well, and the duration of skin contact should be at least till 1 hour after birth, so as to have the so as to obtain the benefits which have been shown in various studies. The benefits of skin to skin contact includes improved exclusive breastfeeding rates, improved thermoregulation in the newborns, improved glucose metabolism in the newborns, and there's also, it's been shown to decrease the length of hospital stay. So delayed cord clamping and skin to skin contact for all stable newborns is recommended in the routine steps only. So now we can proceed on to the, so if prior to this we have seen, if the question to any of the three questions that we mentioned earlier, that was, is the baby term, does the baby has a good tone, and is the baby breathing or crying? If any the response to any of the questions is no, then we'll have to proceed to the initial steps. So we haven't covered the initial steps. So the initial steps include the routine steps with an additional component of stimulation. So the stimulation has to be tactile stimulation in the form of rubbing the back or the soles. However, we should not be spending too much of a time on initial steps, because we have to, if the baby has not responded well to initial steps, we need to start positive pressure ventilation within the first minute of life, and that has been shown here. So the response to initial steps has to be checked by two things: the improvement in heart rate, and if the baby has started breathing or crying. If the baby is still apneic or gasping, or the heart rate is still below 100, then we'll have to initiate positive pressure ventilation as soon as possible, preferably within the first minute of life. However, if the baby has started breathing or and the heart rate is, and if the baby is breathing and the heart rate has improved to more than 100 per minute, then we'll be observing the baby for labored breathing, or if there's any persistent cyanosis. If the baby has a distress, or if there's cyanosis, then we'll position the baby again and clear the airways if required. We'll attach a saturation probe to the right arm of the right upper limb of the baby and provide oxygen as needed. The provision for oxygen would depend on the preductal saturation target, as has been shown in this table. This 1 minute, 2 minute, this minute wise specific targets which we need to maintain. Especially in a preterm infant, we need to consider continuous CPAP, that is continuous pressure, continuous positive airway pressure. So now we're back to the main algorithm. If after initial steps the baby is apneic or gasping, or the heart rate has not improved and still below 100 per minute, then we'll proceed on to positive pressure ventilation. Now we can give positive pressure ventilation through either self-inflating bag, a flow inflating bag, or a TP resuscitator. So the benefit with self-inflating bag is we do not need a compressed air source for functioning of this self-inflating bag. However, for a flow inflating bag and a TP resuscitator, we would require a compressed air source and a little bit of expertise before using these instruments. However, the benefits with these flow inflating and a TP resuscitator would be to provide, while resuscitating, we will be able to provide positive end expiratory pressure, which may be difficult with a self-inflating bag without a PEEP valve. So in most of our settings, we'd be resuscitating most of the units in India, especially in SNCOs, would be resuscitating with a self-inflating bag, and that is okay. So at the time when we are starting PPV, one of the other team member would be attaching a saturation probe to the right upper limb, and if there's a provision of ECG monitor, then we may consider putting an ECG monitor as well. So the frequency of positive pressure ventilation is 40 to 60 beats per minute, and one may count for this frequency, one may count like 1 and breathe in, 1 and 2 and breathe in, 1 and 2 and breathe in, to provide an approximate 40 to 60 breaths per minute. The first assessment after positive pressure ventilation would be done at 15 seconds after the PPV has been started, and the assessment is the improvement in heart rate and the chest rise. So if so we'll be looking at the heart rate after 15 seconds. If the heart rate is not improving or is still the same, and there are no chest or inadequate chest movements, then we'll be taking the ventilation corrective steps, which goes by the mnemonic MR SOPA. So the MR SOPA stands for M for mask readjustment, R for repositioning the baby, so as for suctioning the airways if there's secretions, O for open the mouth, P for increasing the pressure, and A for alternative airways. So we'd be going through each of these steps one by one and look if there's adequate chest movement. So once the chest movement is adequate, then we'll continue with positive pressure ventilation for at least 30 seconds. So the important aspect here is the chest, there should be effective ventilation for at least 30 seconds before the next assessment. So we'll be looking at the chest movement, and if there's adequate chest movement for at least 30 seconds, so we are sure now that the baby has been ventilated adequately for 30 seconds, then we'll assess the heart rate again. If the heart rate is below 60, then we'll have to proceed on to the next step, that is chest compression. However, if the heart rate is between 60 to 100 beats per minute, then we'll need to again consider the ventilation corrective steps and continue with PPV till the heart rate has improved more than 100 beats per minute. If the heart rate is here more than 100 beats per minute, but the baby has not started breathing, then we'll still continue with the PPV until the baby is spontaneously breathing. Now, if the heart rate is below 60 beats per minute, then we'll proceed with chest compression. So next slide, please. Next slide. Yes. At this time, the baby should have been intubated and the FiO2 should have been increased to 100%. Before initiating the chest compressions, we need to also consider ECG monitoring. So once the chest compressions has begun, we need to coordinate it with positive pressure ventilation. So the chest compression and positive pressure ventilation has to be coordinated in a 3:1 ratio, and we'll be delivering 120 events in 1 minute. So there would be 90 chest compression and 30 positive pressure ventilations in 1 minute. And for coordinating chest compression with PPV, one may count like 1 and 2 and 3 and breathe in, 1 and 2 and 3 and breathe in. So there should be adequate, appropriate coordination between chest compression and PPV. After 1 minute of this coordinated chest compression and PPV, one would be reassessing the heart rate. If the heart rate is still below 60 beats per minute, then one needs to consider the use of IV medications. So the IV medication which is recommended is epinephrine, and the strength has already been mentioned. There should be 1:10,000. We should have prepared prior to the delivery. And the dose, which is the preferred route, is umbilical venous route, and the dose is 0.1 to 0.3 ml per kg. However, if the umbilical venous route has still not been established, one may consider giving it through endotracheal route, but the dose would be different. The dose is 0.5 ml per kg to 1 ml per kg. Through the endotracheal tube. However, the absorption through the endotracheal route is erratic, and one may need to re-administer the drug dose once the venous line is established. After at the same time, one has to continue with chest compressions and positive pressure ventilation with ongoing assessment. If the heart rate is still below 60 beats per minute, and especially when there's blood loss in the peripartum period, then one may consider hypovolemia at this time and administer normal saline bolus, that is 10 ml per kg over 5 to 10 minutes. If the blood loss has been severe, then one may also consider O blood group, Rh negative blood at again 10 ml per kg over 10 to 20 minutes. So, but in case of a preterm infant, we should be cautious about this rapid bolus, and we should probably consider a slow bolus rather than a fast bolus. So, we'd be assessing, we'd be continuing with the chest compressions, and if needed, the repeated bolus of epinephrine up to 2 to 3 epinephrine doses. If the response to your resuscitation has been persistently poor till 20 minutes of after birth, and there has been no signs of this has been inadequate response, or the heart rate has been persistently bradycardic, then we may consider withholding the resuscitation only after 20 minutes of adequate resuscitation. So that's all for resuscitation guideline. So over to Dr. Somsekhar. Thank you, sir.
Yeah, thank you, Dr. Mayank, for a pretty detailed question. I think ask questions there because there are quite a few questions that I've asked, and they are kind of urgent. So if I go to the next one before we ask more. Dr. Ruchi Trivedi has been asking questions. Sometimes it is a few questions. One is asked, has the criteria changed to only breathing or not? And we were not. So can you comment on that?
The NRP guideline, which has been now released in March, recently in 2020, it still mentions the criteria. I think what Dr. Rutvi means here is the initial assessment, which is just after birth. If the baby's term, if the baby is crying or breathing, and if the baby has a good tone or not. So this has essentially been remained unchanged from the previous recommendation, and we still are going with these three basic questions.
Yeah, so I think the confusion there are two algorithms in India as well as in the US. There is something called as the helping baby breathe, and we have the so these are kind of similar, and they are generally considered as basic neonatal resuscitation programs. They are more or less targeted, and there the initial box actually talks only about breathing, and the subsequent steps are similar. To go only till back and mass resuscitation. In the as you saw in the algorithm, you go up till incubation and incubation and everything. In the basic therapy or BB algorithm, there's only breathing mentioned. And that's probably the reason that's one. So in the NRP algorithm, there are questions as Dr. Maya said, they have not changed. Now, she another question for delayed cord clamping. Is it an aims and heights period of 6 seconds? So is it the
So regarding Yes, sir. So regarding delayed cord clamping, there has been different recommendation from different bodies. The American Academy of Pediatrics, as well as the recent guidelines which has been launched in 2020, mentions that the cord should be clamped at least after 30 seconds, which was earlier 30 to 60, at least 30 to 60 seconds in the 2015 guidelines. Now has been changed to at least 30 seconds, while WHO recommends to delay it at least 1 minute. So there's some discrepancy between the different guidelines which have been given by different bodies, but the NRP guidelines by the AHA and the AAP mentions it as at least 30 seconds after birth.
Yeah, thank you, Dr. Mans. So the reason why this happens is because there are different people and Canadian network or the USA. They come about European guidance suggests 60 seconds as opposed to with 30 seconds. The AIMS and IC protocol has based the guidelines, which are 60 seconds. So we would look at that. If you want to teach, I would say you can choose between 60 seconds or 1 minute, which is shorter. So I think because more and more evidence is coming to clapping benefit, and there was one article in the about resuscitation. That is something which is very guidelines, but I don't trust that. Now, Dr. Bhavana has it is mother or initial.
So probably Dr. Bhavna is talking about a stable late preterm baby from the scenario which he has put. And a late stable preterm baby who is having normal heart rate, crying, good tone, can be very well received on the mother's abdomen and then can be subjected to breast crawl. But at 35 weeks, usually 34 to 36 weeks is the time period for a coordinated suck to establish to begin to establish. So these babies are expected to have a good sucking reflex, and if the sucking reflex is good, then can be promoted out for breast crawl and breastfeeding also. Otherwise, there is no contraindication for skin to skin contact. And it has been found, as I showed in the various studies also, the babies who are big enough, more than VLBW, and those who are late preterm, skin to skin contact can be easily established in these babies. By skin to skin contact, I mean very early skin to skin contact, that is immediately after birth. So there is no such contraindication in these babies for any skin to skin contact. And manage them on the mother's abdomen instead under warmer.
Yeah, thank you, ma'am. Rutvi is again asking for time recording during resuscitation. Separate personnel, Dr. Maya.
The team should constitute as I think we have already discussed about the manpower requirements. So if there's even for a uncomplicated birth, there would be requirement of one person who is trained in NRP, and the team may include an additional team member for time recording as well, especially if this becomes important in cases of a complicated birth with additional risk factors. So there would be 2 team members and 1 additional team member for timekeeping. However, since our systems in our units, there may be a shortage of manpower. So this may not be feasible in all settings, but ideally there should be one person who would be looking at the time.
Okay, thank you. I think a few questions are on delayed cord clamping. We can take the questions in the end. I invite Ms. Meena Joshi, who is a experienced and dedicated nurse educator in All India Institute of Medical Sciences, New Delhi. And she'll be talking about a very important aspect, post-resuscitative care of the babies who have been given some form of resuscitation. I invite Ms. Meena, please. Thank you.
Okay. So now the neonate who has been resuscitated and require post-resuscitation care. So we have to monitor them very carefully. Why? Because they may fall sick again at any time. So next slide, please. So any neonate who required bag and mask ventilation for 60 seconds or more at birth, or needed intubation or medication at birth, are labeled with moderate to severe birth asphyxia. Now, once the newborn is resuscitated, we have to monitor them. So we have to shift them for continuous monitoring into the NICU. So it is very important to tell the parents that you are going to shift the baby to NICU and inform the NICU team that they should get ready to receive the baby, so that proper preparation at NICU is to be done. Now, as soon as you receive the baby in an ICU, of course, you make sure that you receive the baby in pre-warm bassinet. So, other than therapeutic hypothermia, like in moderate or severe asphyxia, sometimes the treatment is therapeutic hypothermia, exclude them. Other babies should be received in pre-warm bassinet. So, temperature is one of the most important things, like this TABC. So temperature is one of the most important things you will monitor after resuscitation. Why it is important to monitor temperature? As we all know that each 1 degree fall in temperature will increase the mortality rate by 28% and late onset sepsis by 11%. And other than this, hypothermia as well as hyperthermia has their own consequences, and we know that hypothermia can affect every organ of the baby. So it is very important to maintain the baby in thermoneutral range of temperature. So the normal temperature is around 36.5, 37.4 degrees centigrade. Now, the important thing which you have to tell to your nurses is that whenever they are taking temperature, it is very important that they should not subtract anything from that temperature. Suppose they are taking temperature from the digital thermometer, so they have to wait till beep comes. Okay, or suppose you are using mercury thermometer, so you have to keep the thermometer in place for complete 3 minutes. Okay, so and moreover, suppose you are keeping the baby in warmer and you are recording the temperature through the bassinet, the probe, then also it is advisable to digitally check the temperature, manually check the temperature. There are many ways to check the temperature. You can use the back of your hand and you can check the baby for taking, for assessing the temperature. So temperature, maintaining normal temperature is very, very important. We know that hypothermia has its own consequences. And that is why it is one of the most important thing to monitor the temperature of the baby. So the important thing to remember is that how to place the thermometer in position and do not subtract anything. Whatever you are recording is the core temperature of the baby. Record that only. Second thing you will monitor is the heart rate. So as soon as your baby comes to NICU, you have to attach the monitor. So you have to check for bradycardia or tachycardia, because we don't know, baby may go into shock. So we have to check the heart rate. We have to check capillary refilling time. Now, how to check the capillary refilling time? So for checking capillary refilling time, you have to press the bony prominence for 5 seconds. So how will you press for 5 seconds? You have to count like 1001, press it and count 1001, 1002, 1003, 1004, 1005 for 5 seconds and see the refilling time. So if it is prolonged, then you have to check the pulses. The pulses are also weak? And then you have to monitor the urine output. See, the fall in BP comes very late. We have to be very careful. We have to see the heart rate, the temperature, the capillary refilling time, and the peripheral perfusion of the baby. So once you have checked it, say CRT, just mention how much it is. If it is more than 3 seconds, it means your baby is not good. Then you have to see the color of the baby. So color comes like the periphery, the central cyanosis, or the peripheral cyanosis, or the circumoral cyanosis. So you have to check the color and oxygen saturation of your baby. So target oxygen saturation is 90 to 95%. So anytime if a baby is desaturating, so you have to think of starting oxygen. And now you have to check the respiratory rate. So how to check the respiratory rate is like you have to check it for complete 1 minute. There is no compromise in checking the respiratory rate. It should be checked for complete 1 minute. And you have to check for the retractions. So the retraction is like upper chest, lower chest, if you sternum. Like, you can use Silverman's ring. So upper chest, lower chest, GP sternum, grunt, and nasal filary. And you have to mark it. So you have checked the respiratory rate, you have checked the retraction. So respiratory rate, if it is less than 40 or more than 60, then you have to be very careful. It means your baby is not good. Along with respiratory rate, if you are having retractions, if you are having grunt, it means your baby needs further monitoring. And then you have to check for abnormal movement. Why abnormal movements? Because either your baby is having jittery or your baby is having convulsion. So next slide, please. Next slide. So as I told you that we have to maintain the normal temperature, and for temperature already session has been taken. So we have to avoid hyper or hypothermia. We have to maintain the oxygen saturation. We have to secure the airway. We have to maintain the target saturation between 90 to 95%. Maintain normal perfusion. Administer normal saline boluses if the CRT is prolonged, and transfuse blood if there is evidence of blood loss. And if there is shock, then we have to follow the treatment for shock. So how will you recognize that your baby is going into shock? So you will see the warning signs of shock. Next slide, please. Okay. So before going into this, warning signs of shock are like weak and fast pulses, extremities cold to touch, CRT more than 6 seconds, with or without color, very pale, lethargy. So you have to check, and you have to provide warmth to the baby, secure airway, breathing, patient temperature, and correct hypoglycemia if it is present. See, if the shock is due to blood loss, or then you have to give fast bolus 10 ml per kg normal saline, followed, you can repeat the normal saline bolus 2 times, and then you have to transfuse blood. As Mayank already said that we can use O, blood group O, Rh negative, and then not forget to give injection vitamin K. Okay. So, and then you have to start the baby on IV fluid 10% dextrose for maintenance of fluid, and you have to check blood glucose and maintain the blood glucose between 60 to 120, and then you have to watch the baby for further signs of deterioration. Next slide. Next slide, please. Okay, I just want to say that suppose if your baby is having seizures, so what all will you do? So if your baby is having seizures, you will take immediately blood sample and you will check for blood glucose. And if you find that the blood glucose, and send for the blood calcium also. And if you found that the blood glucose is less than 45 milligram per ml, then you have to give straight 2 ml 10% dextrose, 2 ml per kg 10% dextrose, and suppose the blood sugar is normal more than 45, then you have to give injection phenobarbital 20 mg per kg IV. It is to be given 1 mg per kg per minute, so over 20 minutes, and then you see your serum calcium, and if it is low, then you can administer serum calcium. One of the important thing which I want to tell you is that sometimes we get confused how to differentiate between convulsions and jitteriness. So it is very important to teach your healthcare providers how they can differentiate between whether the baby is having jitteriness. So suppose the baby is having jittery, then the movement should be fast, and you can provoke the jitteriness by stimulation, and you can stop. If you hold the baby, the jitteriness will stop, and there will be neurological examination will be normal, and the jitteriness is not associated with eye movement or any autonomic nervous system changes. So, but in the convulsions, you will have both fast and slow movement, and you cannot provoke, the convulsion by stimulation, and it does not stop with the restraint, and then the neurological examinations are often normal. Okay, so next slide, please. Fine. So, any baby who is asphyxiated, we have to monitor every 2 hourly for temperature, color, heart rate, as I already explained them, CRT, respiratory rate. It is very important to teach your staff, like we say, for complete 1 minute respiration, and then to report if it is less than 40 or more than 60. Now, how will you advise them to, when we tell them to see for retraction, upper chest, lower chest, but how to tell them where to look for lower chest retraction or upper chest or GF sternum? So, GF sternum, we know we can easily look, but for lower chest, tell them to draw a mid imaginary line in the axilla, and below that will be your lower sternum. Okay, so upper chest retraction, lower chest. So these are the part of the Silverman score. So you have to teach them. Then SpO2 monitor, urine output 1 to 4 ml per kg per minute is considered to be normal. Below 1 ml per kg per minute is to be informed. And then 8 hourly we have to monitor the baby for like consciousness, tone, seizures, sucking, and respiration. Okay, next slide. Anyway, I want to add one more thing here. So that you have to assess your baby for encephalopathy. So if there is no or mild encephalopathy, you can initiate, alternative method of feeding. And once your baby, because this is mild and the gut is not compromised, and you can shift the baby to breastfeeding as soon as the baby is capable of taking. But suppose there is moderate to severe HIE, depending the 5 things which I told you, consciousness, tone, seizures, respiration, and sucking, then you have to monitor the vital sign regularly, monitor the urine output, and you have to start the baby on IV fluids, and you have to start with 60 ml per kg, and you have to monitor the urine output. Okay. So, okay, so these are the things. So the final slide. In also, we have to tell that we have to do the minimum handling, hand washing, maintenance of normal temperature, initiate early breastfeeding once they are hemodynamically stable, blended oxygen, target oxygen saturation, IV fluid when needed, and relevant lab investigation, maintain blood glucose, early CPAP, and counsel parents. So with this, I finish my post-resuscitation.
Yeah, can we continue the next presentation and we'll ask questions later. Dr. Seema Sharma, please.
Thank you, sir. Am I audible? Am I audible?
Yes.
Okay, sir.
Yes.
This is going to be last talk. Good afternoon, everyone. I'm going to talk about regarding the transport of the sick neonates. As we all talking about the care of the preterms, and most of the preterms are quite sick. And during the course of the sick neonates, sometimes we have to transport these sick neonates either to the higher centers or even within the hospital itself. Let's see like what we should do for the transport of these sick neonates. Next slide, please. The best way to transport whenever we are expecting a sick neonate or a high risk neonate, the ideal way is to transfer this particular neonate is in utero transport. But if it is not possible, then certain things to be kept in mind is to keep the resources ready, the person, equipment, vehicle to be ready. Then the pre-transport stabilization should be there. The communication part should be there. The documentation should be there. So these 4 things should be ready. So in this particular table, I have made one checklist. So in equipments and supplies, what should be there? The certain things should be ready in a checklist. Is the to cover the baby, socks, clothes, caps. Then we should keep the things like blanket for resuscitation, bag and mask, suction apparatus, oxygen cylinder. Then for suction, catheter should be ready, stat and thermometer. For IV fluids, in IV fluids or in feeds, EBM if possible, or IV infusion set, IV sets, if syringes, needles, tapes. Then certain antiseptic solutions, napkins, and in drugs, antibiotics if we are going to give, and like adrenaline injection should be there, and certain fluids like normal saline can be there in the set itself. Next slide. Now, when we are talking about resources, what resources can be there in human resources? If it is possible, we can have a team of doctors, nurses, which we can send along with this transport team if it is possible. And if it is not possible, suppose we are sending our baby from peripheral health center to our SNCU or from SNCU to the tertiary care center, then we can train our ANMs or our ASHA worker to accompany the transport team. And in the ambulance or the equipment, yes, we should have at least the oxygen, ventilator, the power backup, infusion pumps, and essential drugs in the ambulance itself. It should not only the availability which should be there, but we should check the functional part of it which should be there. Next slide, please. Now, the most important part is before shifting the patient, we should stabilize the baby beforehand. And we should keep these 2 things in our mind. One is the stable and second is the top. In the stable, what we should do is we should keep the blood sugar levels in the normal range. We should keep the baby's temperature within normal limits. Then airway and breathing should be normal.
we should keep the CRT within normal limits, and the lab, if we have the lab values, then we should keep all the reports in our hands to be transport along with the baby. And the most difficult part of our transport is the emotional support to the family. And the next is we should keep the tops also ready. Tops means the temperature, oxygenation, perfusion, and the sugar. So we should keep these two things in our mind whenever we are sending our baby for further transportation. Next slide, please. This is the most important part of our transportation, that is communication and documentation. In communication, it is the communication between referring and the refer units, communication between parents, doctors, and the feedback back to us, and the communication from us to the referring unit itself. We should talk to the parents why we are sending this patient, the condition of the neonate at the time of the referral, and when we are sending, we should tell them where we are sending, how we are sending, what is the condition, what is the likely outcome of the baby, and then we should get the feedback from the referring unit also. In the documentation, we should keep the referral slip ready with all the details written in it, the phone numbers, the complete address, and the complete investigations, and the consent, the written consent, and we should keep one copy of it with us for the medical legal point of view. And along with that, we should give the emotional support to the parents also. And at each and every point, we should keep all the documentation with us, and we should give one copy of all the documents to the transport team also. Next slide, please. After doing all these steps, what care we should do when we are sending our patient to the referral point? This is a care we are going to give during the transport. During the transport, we should ensure the temperature, airway, breathing, and circulation. How we can keep it? If we are sending our whatever team we are sending along with our neonate, they should keep all these things in place. Then it is best not to attempt, this is very important, it is best not to attempt feeding sick babies with abnormal sensorium or severe respiratory distress before or during transport. So it is very important to give IV fluids if the baby is having severe respiratory distress or if baby is having abnormal sensorium. And we should take the baby to the nearest facility by the fastest mode of transport and by the shortest route. Next. That's the end of my presentation. Thank you so much.
Thank you, Dr. Sharma. I just wanted to ask, let's start beginning asking the question, then I actually will ask this question, which if I can give an opinion, and then we can even ask the same question to other faculty members too.
Yes.
The question is this, if you want to transport a baby from one hospital to another, baby is premature and is on 40 to 60% FiO2 and needs to be shifted to another place because you don't have enough ventilators, or baby requires ventilation, but you don't have, and you have to shift. Now, when you want to shift, suppose on a ventilator, how do you, or on a CPAP machine, how do you ensure a air and oxygen mixture in the transport? So does anyone, because if we are transporting a newborn baby, do we always transport on 100% oxygen, or do we have some facilities for blending oxygen?
Sir, if we have the ventilator facility or the CPAP in the ambulance itself, then we can transport the baby in the fully equipped ambulance in itself. Then there won't be any issue.
So my question is, do you have air cylinders to ensure that air and oxygen get mixed for giving blended oxygen in the transport vehicle?
So, like in high-ended hospitals, we do have, but like in the peripheral centers or in all SNCU, we don't have.
Yeah. So can other doctors also explain? Dr. Rashna, maybe you can go first.
Yeah, in our place, we don't have any of those facilities. So if when a patient has to be shifted, the patient will be shifted on 100% oxygen, maybe on a bag and tube ventilation.
Yeah. Yeah. Dr. Shashidhar, can you put your point across?
It is the same in our unit also, but there are transport ventilators available. So if you have an inbuilt compressor with a ventilator, then there is no problem in blending, but we don't have it as well.
Dr. Jain?
Sir, we have transport incubator with ventilator. Both we have two of these. One is the bigger one for shifting from our hospital to PGI for any cardiac surgeries and all, and one is for shifting from labor room to our ICU. So the both of these are with ventilator. So we are shifting them if they are on CPAP only, then it's a very less distance. It's not only it's not even 100 feet distance, labor room to ICU. So they once they are on CPAP, then they are shifted probably on the 100% oxygen. The resident is not attaching them to the CPAP of the transport incubator. But if they are intubated, all of them are transported on transport incubator ventilator.
Dr. Mayank,
Yes, sir. So in AIMS Rishikesh, sir, we have the Dragger transport incubator with a compressed air. There's air compressor inbuilt and additional oxygen cylinders, which is used to provide the blended the air mixture and the required FiO2. So we shift them on blended air for CPAP as well as for invasive ventilated babies.
okay, thank you. Ms. Meena, do you shift patients? I doubt, but आपके यहाँ पे तो shift नहीं होता होगा, right?
Sir, हमारे
हाँ, आप shift करते हो patients transport incubator या
patient to yes, sir, हमारे we have the air shifting facility also. We do shift with the all facilities are available in the ambulance itself. But most of the times we shift on 100% oxygen. Patients are
thank
poor.
you. Yeah, thank you very much. So now what we'll do is we'll go, because we have our 20 minutes. We will ask questions and maybe you can answer quickly. One is Dr. Shinde has asked, during resuscitation, heart rate should be auscultated or cord pulse is okay. Dr. Shashidhar, can you answer that question?
So the best method of assessing heart rate is cardiac monitor, ECG lead, but that is not available in many of our centers. So the second best probably would be pulse oximeter. But the pulse oximeter, to get the signal, to get the heart rate within first 1 or 2 minutes of life, is a challenge. So we rely on precordial auscultation. The last and least preferred method would be umbilical cord pulsation. So in the order of sensitivity of picking up the exact heart rate, cardiac monitor is first, pulse oximeter, precordial auscultation, and umbilical cord pulsation. So if you don't have the technology to supplement you go by auscultation. Least preferred one is umbilical cord pulsation.
Thank you. Dr. Mayank, what points are covered in a golden minute? Dr. Mayank? Am I connected?
Sorry, sir. I had not unmuted. So, yes, so the golden minute would include the initial assessment after birth, as well as, if required, the initial steps and the initiation of PPV, the positive pressure ventilation, within the first minute of life. So the most important aspect of the golden minute would be the initiation of PPV if required in a baby who is either not breathing appropriately, apneic or gasping, or the heart rate is less than 100 beats per minute.
Thank you. Dr. Shinde is asking another question. Dr. Seema Sharma to please answer the question. What is the role of serum lactate in management of babies in NICU?
Sir, it clearly shows that baby is asphyxiated. In the delivery room, clearly on the basis of lactate level, we don't initiate the resuscitation process.
Okay. So basically, is it okay to say that it does not immediately reflect management in the delivery room or immediate post resuscitation care? It would not make much change. Is that correct?
Yes, sir.
Does any other faculty have a different opinion?
I think the lactate will take some time to come. So our resuscitation should not be affected by this serum, the cord blood lactate. We should proceed with resuscitation. Even in the post-resuscitation care, I think clinical monitoring is very, very important. The parameters which are shown by Meena madam, I think those are, I think, very important. I would go for clinical monitoring and then take a decision.
Okay, thank you. Now, there's another question which was not answered and was asked quite a bit. How to increase the FiO2 through nasal prongs was asked. Maybe Dr. Shashidhar can answer.
When you're using nasal prongs, there is no way to increase FiO2 other than increasing the flow. And when your flow is restricted to about 1.5 to 2 liters, as if you're using non-humidified low flow nasal prongs, then only that much FiO2 you can give, 1 or 2 liters per minute. So that's why the advent of HHFNC or heated humidified high flow nasal cannula, where you can increase the FiO2 by playing with the blender, or use the CPAP, which is better, or use an oxygen hood to increase the flow and make it 5 to 8 liters per minute. Then you can increase the FiO2 to as much as 80 to 90 per minute. So there is not much scope to increase FiO2 if you're using low flow nasal cannula.
Thank you. Dr. Jain, there's a question by Dr. Amit Soel. Cord blood pH means arterial or venous is his question. When people say cord blood pH, it is arterial or venous?
Talk about cord blood gases interpretation for a purpose of defining asphyxia, its degree. It's arterial cord blood gas. It has to be taken in between the two clamps. Problem is most of the residents are committing one or the other error in taking the cord blood gas. By directly pricking and taking, it has to be taken in between the two clamps and has to be arterial. And if you are not able to do it, it's okay, you can take a venous, but there is difference in the venous and the arterial markers with respect to pH especially.
Thank you, madam. Dr. Seema Sharma, when to investigate for end organ damages after resuscitation, and is it based on blood gas or Apgar? When to investigate for end organ damages and other organs also when to investigate?
Sir, that depends on the severity and that depends on the clinical condition of the child. Sir, if the perinatal asphyxia is moderate to severe enough, we can send the labs to find out the condition of the baby, to find out the end organ damage. This can happen even immediately at the time of admission, and subsequently we can find out the follow-up labs also. But the plan will depends on the management will depend on the clinical condition of the child. We are not going to treat the labs. We are going to treat the child on the clinical condition.
Thank you, Dr. Mayank. There's a question for you. You talked about stopping resuscitation after 20 minutes of resuscitation. if I remember right, in the previous book it was written 10 minutes of asystole after good resuscitation. So is there any difference between the previous guideline and this guideline in terms of whether it is 20 minutes of asystole after complete resuscitation or just 20 minutes of resuscitation?
No, sir. It's the so there's a change from the previous guidelines. The time limit that was at 10 minutes now has been shifted to 20 minutes, and it's still the same. The 20 minutes of asystole after adequate resuscitation.
Yeah, thank you. So basically, what has happened is they have just increased the time from 10 minutes to 20 minutes. And the reason, can you explain why did they increase? Would you have an idea, Dr. Mayank?
Yes, sir.
Why did
Yes,
they
sir.
increase?
Yes, sir. Yes, sir. So there has been observational studies where it has been found that the babies who had prolonged resuscitation till 20 minutes with almost Apgar of 0 to 1 had had a good outcome. In terms of neurological, there was the intact survival was in fact seen in such babies, though the proportion was very less, probably around 20% or so, but there was intact survival with such prolonged resuscitation as well.
Yeah, thank you. So one of my residents was just talking to me yesterday. I am actually in a jungle right now, and we were taking a trip, and he was recounting of a baby that he resuscitated after 15 minutes, and he had given up when then somebody suggested that you should try again. And he said baby improved, and then he now still remembers the baby coming for follow-up even after 1 year of having asystole during resuscitation for at least 15 minutes or so. So the point, I think what we should remember is that it's not that babies will not have a good outcome. Okay, so it's important to understand that when babies are getting resuscitated, especially in the delivery room, it is likely that brain damage may not have occurred. So we do not know. So that's very important. We do not know. Now coming to the next question, Dr. Umesh Khurana has asked, is there any specific recommendations for resuscitation if mother is COVID positive? Maybe Dr. take this question.
As far as COVID positive mother resuscitation is concerned, resuscitation goes the same way. It's the difference that is there with the COVID positive mother is that you are wearing your protective gear, you are wearing the gloves, you are wearing PPE kit, and the resuscitation. Some of the units they did started using a resuscitation head. There are two types of these heads. There are two ports, and they would intubate through these ports. As far as the suction is concerned, the data is for severe birth asphyxia and COVID positive is not out. But during resuscitation, going through these two ports, it was an open suction done. Later on, the inline suction. We also had a baby who was intubated, so we were using in that inline suction just as a matter of precaution. Although inline suction in units is not much proven. So resuscitation remains the same. It's your protective gear that will change.
Thank you, ma'am. Dr. Shashidhar, I have a question for you. By Dr. Archana Jivane, are plastic bags to be warmed and how to sterilize it?
If you're talking about the cling wrap or the plastic wrap, which is applied to the baby, it is a single use. So we use it on each baby separately, and before use we send it for gas sterilization. I'm sure, I think it must be other methods also to sterilize, but we are using ETO sterilization before use, and it's a single use.
Yeah, thank you. So does everyone sterilize the plastic bags, or are some of you are not sterilizing the practice bag? Faculty members, please, can you give what are the things that you use? So Dr. Shashidhar is using ETO. Maybe Dr. Suksham, what do you do? How do you sterilize the plastic bags?
There are single-use cling wrap which are available. So open it in a sterile manner. So this is not a cling wrap roll. So it will just fit in for one baby. And then this is what we are using is a single-use cling wrap, which is okay only for one baby. It is not very huge in length and breadth. Then another is the one which most of us are using, the sterile plastic drapes that are coming as a in abundant supply in most of the units. These are the one which are being used mainly by obstetrician. So these are for length and breadth probably of 5 feet or so for a person, and these give you a bigger surface area to cover the baby. So these are already coming as single-use packed, already autoclave sheets. So this is what we are doing. We are not sending them for ETO. So we are using the single sheet only, which is already coming as a autoclave one. But if you are using a big roll, then you can cut them in pieces and send for ETO.
Thank you, ma'am. This is Dr. Mayank. Dr. Rutvi is asking, what about recording time in the radiant warmer during resuscitation and after delivery, as some of the warmers have that facility, and reliability and whether we should use, she's asking.
Yes, sir. So some of the warmers come with an UpGuard timer, and it would show the time in seconds and minutes, and it would it would have up till 59 minutes or so, I think, and then it again switches to 00 time. So yes, if the timer has been switched on just at the time of birth, then it can give a very it can give a very good idea about the timing of the events, and it can help in the timing of the steps if required. Yes, sir.
Thank you. There's another question. I think Dr. Seema Sharma can answer this. Dr. Bhavana Gupta is asking it. In case of baby with shock with evidence of blood loss, do we transfer O negative blood without any cross match?
Sir, I'm not getting very good articles on it, but yes, in certain articles, they are saying that in emergencies, O negative blood can be transfused without cross match. But I'm not getting very good clinical evidence of it.
Yeah, Dr. Rashna, can you share your experience, or you have any evidence that you have looked at?
No evidence as such, but yes, if it is very urgent, we have used O negative blood, but we do try to get a cross match as soon as possible. But our blood bank would obviously, the blood bank officer would give you the O negative blood only for transfusion.
Thank you, ma'am. Any other faculty member has a different opinion with respect to O negative blood?
Sir, the NRP guidelines that has been published recently mentions that uncrossed match or non-crossed match O negative blood can be used in emergency. Again, resuscitation is an emergency procedure, and therefore non-crossed match O negative blood can be used.
Yeah, thank you. So I think this thing about O negative and non-cross match blood is there in most textbooks. And I don't think there are articles in it, but it has been there for for quite some time. There's also, I remember reading in a PCNA quite some time back, maybe 30 years back, with respect to antigens or immune system being developed for antigens for blood given this way. So you don't really get much reactions, but I that's quite some time back I have read it. There are more questions, so let's go to the next one. Now I think I will ask this to Dr. Shashidhar. Why is ECG monitoring preferred during resuscitation? Question is why?
Yeah, so because it is more sensitive, that means if you're auscultating the heart, many times you're not sure whether there is a heartbeat or not. And ECG picks up the electrical signal, so it is more sensitive in picking up, and it estimates the heart rate when you are auscultating compared to ECG. They say auscultation misses about 10 to 20% of the heartbeat, and ECG picks up 100% accuracy. If you say ECG is a gold standard, so that's why ECG is preferred, though it is not come to practice, especially in our nation. But I think NRP 2015 recommended it, now 2020 also has recommended it. So if you have resources, you should think of keeping an ECG monitor and applying ECG leads as soon as the baby is born and connecting them when it is needed to count the heart rate. So counting the heart rate, the best method is ECG.
Thank you. Now this is for Dr. Jain. Till 20 minutes of resuscitation after birth, if baby is not improving, how many doses of adrenaline can be given? And he is asking whether up till 3 or total 3 kind of.
So up till 3 has been recommended. It's not like adults. And if you are giving by intravenous access, then the doses remains 0.1 to 0.3. You may go up to 0.5. But if you are giving by ET route, then the doses definitely increase for up to 0.3 to up to 3. Because you have to, the intratracheal route absorption is poor. But the number of doses, nothing more than 3 is being recommended. If there's some change in 2020 in recent guideline, I am not sure about it. Maybe Dr. Mayank can comment if there is some change in the dosage, number of the doses.
As ma'am, there's no mention of actually the maximum number of doses, but usually this the maximum number is taken as 3.
Yeah, so I agree. There is no particular amount of dosing that is there. There is no restriction of the number of dosing, but people generally would go up till 3, and it depends upon how good your resuscitation is. Now, we really don't have an answer to that question because you rarely end up with that kind of situation too often in a year. So it's really difficult to kind of do a study. Now, again, this should for Dr. Seema Sharma. Does intrapartum soda backup administration in severe acidotic neonates recommended?
No,
I guess
sir.
she's saying that after the baby is born. Yeah.
No, sir. And as per the NRP guidelines, now there's no role of soda bicarb administration. We don't give.
There's a follow-up question. If a baby is not improving up doses of adrenaline, should we be giving IV calcium for poor cardiac activity?
No, sir.
Dr.
No, sir.
Krishna again. No.
We don't give.
Good. Let's see. Yeah, so let's see what more can happen. I've been getting messages that there is still disturbance, and I'm guessing it is from my side because I have poor internet connectivity. Just bear with me for this Sunday. Good. Now, there's a question by Dr. Amit Suyal, and I will ask it to Dr. Rashna Das. Does EEG as a routine part of post-resuscitative care in birth asphyxia recommended? Any role in prognostication?
No, not routine EEG. I don't think so. We are doing routine EEG. I don't know the practice names, but I have not read about routine EEG because there are changes which can occur. The human brain, the neonatal brain is very plastic. So taking one-time EEG and predicting the outcome is very, very difficult. We know that even very highly asphyxiated babies have very good outcomes.
So one of the simple things about EEG is that it is very difficult to read, and there are very few people can actually read EEGs, and we really don't know. There's actually a big, nice textbook on reading EEG in neonates, but most of us would not know, and so doing something which we do not know how to manage is not a very good thing to do. Apart from that, I doubt there are any studies which looked at EEG. It's mainly MRI which has been used as a more better prognostic in birth asphyxia. Anyone else wants to comment?
Sir, as far as EEG is concerned, it's not for prognostication, but for deciding whether you want to cool or not. Again, most of the units are using for cooling TOBY criteria, and the one who are not using TOBY, they may land up in doing EEG. And it's an amplitude integrated EEG, 2 to 4 channel EEG is the one which is being used. And if you do not have it, don't worry. You can use it once the baby is being cooled rather than deciding for cooling. Because for deciding for cooling, you have your Thompson criteria, moderate asphyxia, seizures, your blood gas, and obviously the baby more than 2 kg and more than 1. So cooling, if you're doing by Toby criteria, you may not go ahead with the EEG, and you can apply EEG once the baby is being cooled. And routine EEG just for prognostication is not being used, as Dr. Ashna has nicely said that it will keep on undergoing changes. More so, maintaining these electrodes on the forehead for a continuous EEG monitoring, you keep on coming out. And if your ohms is more than 5 ohms, the reading which is coming is actually fallacious one. So it will keep on signaling that it's not correct. You have to maintain these electrodes on the forehead, and they keep on coming out. So there isn't much role I haven't heard of for prognostication. It's used only for deciding for cooling.
Thank you, ma'am. I think that's very nicely put. So I because I thought he meant EEG, but if you want to say amplitude integrated EEG or AEG, then it might be a good thing to use it if it is available, but that should not stop you from going ahead with what do you call as cooling babies. It's not necessary. The largest trial that was done probably did not use amplitude integrated EEG, and they have used it based on clinical criteria, which is good for us because most of us would not have access to this particular equipment. We are at 1 o'clock, and I think we should stop. There are still more questions that are being asked by participants, but I think we should stop. Doctor, anyone has any comment to make? Maybe all of the faculty members, starting with Shashidhar, can just make one point, and then we can hand over to Dr. Pratima.
Yeah, so I just wanted to make the point that it's in preterm resuscitation in the delivery room, the golden hour which is the most important. And if you don't do perfect management within that golden hour, then whatever you do later is not going to add up to the exact good outcome that you're going to reach. So you should anticipate and you should prepare yourself, do the best management in 1 hour regarding basics like TA, BC. Without much technology, you can still achieve all this. And to achieve good outcome, you need that golden hour.
Dr. Rashna.
I think I'll use Rishi's lines that if you fail to prepare, you're preparing to fail. So preparation is very, very important. Keep all your equipment ready to use so that you don't lose any seconds while you're trying to resuscitate the baby.
Dr. Suksham?
Sir, Dr. Shashidhar has nicely put it, TABC. I remember when we were used to give this SNCU training, even the sweeper who is there at the end, he is also speaking TABC. So it actually goes in, it hymes in you, and when it is hyming in you, you are maintaining that. So go for it as TABC, because temperature in these tiny preemies is very important.
Dr. Mayank, there's a question you can answer and then say something. It's about tactile stimulation, flicking touch of the soles during the resuscitation, and then you can comment.
Yes, so this has been mentioned in the recent guidelines that rubbing tactile stimulation is rubbing the back or soles. Now they have removed the word flicking the soles, so it's now rubbing the back or soles is tactile stimulation.
Go ahead. You have any?
Yes, sir. So I would like to emphasize to everyone that 90% of the newborns would not require any kind of resuscitation, and the only the step is required is delayed cord clamping and skin to skin contact. So for all stable term as well as preterm infants, and for all vigorous newborns, the delayed cord clamping and skin to skin contact with mother for at least 1 hour after birth.
Thank you, Dr. Mrs. Meena Joshi.
I think she had some network issues, sir. If we can go ahead, sir. She messaged me.
Yeah, Dr. Sharma, please.
Sir, I just want to say keep stable in your mind when you are transporting a neonate. That's it, sir. Thank you.
Thank you. I thank all the faculties for ensuring a very lucid presentation and discussions. We have still some questions left unanswered, but we can carry on in the Telegram chat. I am starting my video because I am in a jungle currently, and I had poor connectivity. So I'm sorry for not being able to join on time earlier on. So thank you all, and thank you for all the participants for joining and asking pertinent questions. We will move on to the next week. Make sure that you please answer the quiz link that Dr. Pratima has put up. And many thanks to Dr. Pratima for ensuring that this goes on time as well. Thank you very much. Dr. Pratima, can you go ahead and say a few words and then we can close?
Thanks, thank you so much for making it on a Sunday. You all, I think it helps the students, and we all are here for the cause of the newborn care. Thank you.